So why the name Black Men's Health Clinic? Because nobody is gonna take care of us except us. With the Black Men's Health Clinic, we can change the way services are coming to us as men of color.
We serve a client base that has extreme barriers. So for Black Men's Health Clinic to be able to understand those barriers and still be able to help us provide healthcare services represents great partnership. Being able to let these clients know no matter what status, no matter what health conditions they come in, they will be able to receive healthcare. It's phenomenal. We really appreciate Black Men's Health Clinic making their services so available to our unhoused population.
Well, I believe the clinic positively impacts the community by providing services that the community needs, provides awareness, knowledge. Also, it's a great place just to come get checked. You know, a lot of people never get checked in this community. And by them offering their services, working with the community, I'm on board with that.
When we first opened in Austin, we didn't have a location yet, and we were looking for a place to locate where we could service our patients until we get a full-time clinic open. And Black Men's Health Clinic offered to allow us to share their space with them so that we had a location to help our patients in the meantime.
Having the Black Men's Health Clinic as a partner has enabled us to reach a whole nother type of population. Being able to deliver healthcare services to these individuals, we wouldn't be able to do it without Black Men's Health Clinic.
I believe in the vision that Dr. Wallace is heading the ship. I believe in the direction, I believe in the heart of this industry. I believe that us working together can achieve a great goal together.
If I could say one thing to the Black Men's Health Clinic, and in particularly Mr. Wallace, who has allowed us to partner with him and share this space while we've established ourselves at AHF, it would be thank you. And I am very grateful that he's given us the platform to spread our message and also allowed us to partner with him in spreading his message. So I'm grateful to have them here. I'm grateful we've had a chance to work with the Wallaces, and I look forward to everything that they can do in the future.
Shout out to founders, Larry. I appreciate y'all giving us this chance, being behind us 100%. Love the growth that y'all going through, just watching it every day, going to your IG page, I love it. I want to thank y'all for bagging us, because we did need the help for that vision that I told you that I want to see. Give out a scholarship two times every season, 2 scholarships for the struggling college players or students. Also, let's keep it going so it can grow together, because it's a beautiful thing we got, and I really, really appreciate y'all.
Thank you so much, Mr. Wallace, for having your vision and for making healthcare for men of color in the Austin area a priority. And thank you so much to the rest of the Black Men's Healthcare team for teaching me so much in my internship so far.
I want to thank the founders, or should I say the visionaries and the leaders of the Black Men Health Clinic, and let them know what they're done, what they have created is off the charts for the African American community and the people of color. It was a service that was not here and was not provided before. Healthcare providers who delivered services originally didn't look like the clients that needed the services. So at that point, there was an under ratio of people taking advantage of healthcare services. Now that we have Black Men's Health Clinic, we have clients that are comfortable and excited about their healthcare and utilizing these services now in our community.
Dr. Larry Wallace Jr., serving as the board chair for the Black Men's Health Clinic, and I am so appreciative of all the partners, everybody coming together to help build this Black healthcare system. I mean, my friend Eric Bird, president for the Black Professionals Alliance, said it best. What we are doing here is working with the system, helping to find gaps and mitigate those, in which you all coming to the table, and hopefully even more over the next year, we can continue to reduce the barriers of access and equity that are so much needed for our population of Black and brown individuals. Thank you for your support this last year, and we hope to see even more the next year.
My name is Larry Wallace. I'm the founder and president of the Black Men's Health Clinic. The Black Men's Health Clinic is here to really serve and meet the needs of all men of color. We believe that the services that we provide are life-changing for men and for their families. And without the work that we do, men would be suffering without solution. So we really appreciate and we're grateful for the partners, because without you, we couldn't do this work. But with you, we're able to really advance and make a difference in the lives of people. So again, from my heart, I just want to say thank you to all that have helped this vision to be manifested, and the best is yet to come. Thank you.
We'll just dig right in. So I want you to share a little bit more about Black Men's Health Clinic, the vision and how it started from an idea and then really transformed and beyond.
Right. Yeah, I think like anything, everybody here is creating their own vision.
And finding where to be able to help individuals, and you have your own passion and belief of what it is, and then the actual reality of what it must become. And so I'm gonna speak a little bit on his behalf for Larry Senior, which was, you ever saw Tim Allen with the old show Home Improvement and all that stuff, right? It was kind of that visionary of a health clinic with cars and just a place to go in. And it was just really just men-centric. And then the reality sometimes comes in as far as funding and need to get funding and space available, and how much of a debt do you kind of take on trying to get something like this launched? Where is the proximity that it probably needs to go to? In some of the industry that you come from, you have certain resources, but then when you go out to venture on your own, those same resources are not necessarily readily available like they were. And so it really morphed into an aspect of picking one central location, one building. It didn't really sell the normal perspective of a clinic, that feel, that appeal. And we had an opportunity to move right across the hall in a former place of one of our partners, Community Care, Central Health. They used to do medical access program enrollment processes. And so we moved over there, and it had a better kind of a clinical feel and presence. And so we took on a larger debt to be able to meet that connection point of what people think within the healthcare aspect. And so from there, it really morphed into an aspect of what can we put in this space as far as tables, as you saw in the video and so forth. And then in the waiting room, how can we make that less overly healthcare? How can we make it more of a calm place? Other organizations can hold events there and get acclimated to health that is non-intrusive. And so we kind of shifted in that aspect of less heaviness on health and more about the actual population we're trying to hit. And you'll, as we talk more, really understanding that niche amongst our partners to figure out who that target population was versus initially on just a place for men. in general, and it needed to be macho to a certain extent, to more of, all right, who is really that gap within the overall population, and how do we need to tailor it so it messages to them?
I love that small detail to, or the attention to the small details, which really matter. And the fact that you thought and had to think about the placement of tables and what that environment looked like to make essentially people feel more comfortable.
Mm.
And I love what you all have done in terms of the partnerships that you've created. It sounds like it's taken so many partnerships. We've only seen one small iota of the partnerships that I'm sure you've had to create over so many years to be able to create this into a reality. Can you talk a little bit more, and you mentioned it, about the community care
Mm-hmm.
and that relationship, and then some other partnerships that have been quite pivotal for you all?
So we've only been in existence, quick timeline. You saw it for a quick bit, and there's probably another half of a video if you ever want to look at it. And so we started planning in September of 2021. First services were actually in June of 2022. So less than a year providing services. We just got done doing our second quarterly report yesterday, so I can tell you these numbers. So we have 161 new clients, with roughly 75% of those physical health appointments. The other are mental health appointments, and roughly 40% are medical access programs. So insurance-like type of support and care. And community care was our first provider. They were the biggest ones, biggest supporters. And so a lot of our support and what we're doing is through partners first. And really saying from a sense of Larry Sr.'s background is public health administration, dealing with people. My background experience is also dealing with people, and trying to do this approach of more of, let's get outside of the healthcare jargon. Let's get outside of our assumptions of what people think and how they think, and actually going towards, how do you feel, right? Why are you not coming? There's a clinic right across the street. Why are you not going to that clinic? There's a clinic 2 miles down the road. Why are you not going to that clinic? Whether you have insurance, don't have insurance, whatever it may be. And so we really looked at it and said, there's clinics, there's hospital systems there. Why are we going to create something new just because a gap and a barrier exists, versus forcing the system in an aspect of accountability to work amongst itself? And us being a catalyst to be able to help do that and say, in your normal system, you haven't done it. For decades, you haven't done it. In the reports, you haven't done it. You keep saying it needs to be done. So, hey, use us. Let us be the pilot, because there's a lot of things you can be able to get away with when you're saying, I'm piloting, right? We're trying something innovative, we're piloting, right? And so in this sense, that's basically what we're doing. We're giving them an out in a way that they need to do something, know they need to do something, but the bureaucracy and the red tape takes too long because of how big of an organization it is. And so with us, we're saying, hey, do it our way. If it moves the needle, now you have credibility, now you have data, you're at the table, so you don't need to spend another 5-10 years to verify it. You're in it to begin with. And then hopefully, as we move the needle, or if you say academically, our sample population versus your sample population, which one is actually having a better impact? Oh, our sample population. So why don't you go ahead and take this and now reverse replicate it throughout your whole system? And so that's kind of the short ball game. The long ball game is, because we're working with federally qualified, I know I'm going long, tell me this.
No, this is great. This is fantastic.
That because we're working with federally qualified healthcare centers, that's a lot of money we don't have to pay out of pocket with taxpayer dollars, right? So it's a level of accountability, the level of innovativeness to enhance services to people of color. Plus, we're able to now take 90% of the funding that we're receiving and putting it in bodies that their whole mission objective is to build warm handoffs, engagement, to where all of us, we're like, man, I hate this system. Customer service today, just in general, is just horrible. You talk to one person, you talk to the next person, like you never talked to the first person, right? And so that's what we're doing with our funding is outreach people, navigators, like Amazon, and everybody talks to me, here's this scenario. When you pay Amazon, it says, and it gives you the option today, tomorrow, or 2 days. You don't care if it touched 10 people, 50 people, you want it today, tomorrow, or in 2 days. And so that's kind of our model, which is fund us to do the stuff you can't do, which is care navigation, which is care coordination and health navigation. That piece of making people feel comfortable, making people understand what to expect, why they need to fill out certain paperwork, why they need to show up an hour ahead of time, right? Just those basic things can help make people more comfortable and actually show up. And we're saying, since we're partnering FQHCs, we don't have to spend that money on primary care. We can spend that money more as a payer of last resort, which is another concept that we wanted to do, knowing that some people may not be eligible for pay scales or eligible for free services, right? And then you have people that are on the pay scale and they still can't pay the copays. So they don't come. And so we're saying we're taking that money, because we're working within a system of accountability, to now be able to help bridge where other people that normally probably wouldn't go see the doctor can now see the doctor, because as a client of ours, we're saying we will be a payer of last resort for you, right? And I think I went way off of what you
Oh, but
asked.
this is incredible. And there's so many questions I want to tag onto from that. But this is, it's interesting. Can you expand a little bit more? I'm going off script, sorry. But we want to expand on this payer of last resort. Can you talk a little bit more about that and the experiences that you've had and how often you've had to be that payer of last resort?
So we've been a payer of last resort. Honestly, even though we're focused on men, we've coordinated health services for ladies, for youth, both on the male and female side. Our providers, they take care of everybody. The only thing I think we're really restricted right now is this pediatrics, because we don't have that type of a provider. But we do not restrict our partners from taking care of whoever they need to take care of. There's lack of minority providers and just healthcare individuals in the east side of Austin and Travis County to begin with. So we're not just siloing. We understand that there's 3 or 4 roles that we play as a clinic when it comes to building more people of color within the healthcare system, getting with the realization right now, the healthcare system, that there's not people of color. So, hey, understanding that if they're partnered with us, there's a level of understanding. They're going to treat you like a person, right? And so I don't care if they see someone, I want them to walk with it. That was a cool white person, right? that person was cool. And so that's the goal, is understanding where we are now, trying to grow it. That's where you see all the school connections. The also aspect of just trying to change the way people see and feel about healthcare. Community care, they have roughly 900 individuals, Black males, that they have enrolled with them that are not actually using, right, the services. But our concept is, if we only help them get those 900 into the system and start using it, we're just like everybody else. If we can't get them to go from 8% of Black population enrolled into healthcare to 9%, then we're actually not moving the needle. We're just doing the same thing everybody else can do.
Wow. So not only do you improve, right, the access and the accountability, I love that word, the accountability for the people that were already enrolled in the system, but then you also push yourselves to over-enroll, like the 161 new clients. It sounds like, were those already enrolled and already seeking care, or were those new clients that then you enrolled to push to the 8%, 9%?
Right. So 161 is new enrolled with us as Black Men's Health Clinic. They say they want us to be their provider and their coordinating entity. Some are just brand new, haven't seen a doctor in a while. We're still working on those numbers, so I'm not going to give you numbers and it'd be wrong and so forth, right? I mean, we're only in our second quarter of seeing people and perfecting data collection and so forth. But that's why we're also partnering with these academic schools. We have interns from UT School of Social Work. I mean, Madeline Johansson's been doing an amazing job of making sure that on the backside, we are capturing the data. We are doing the things that matter. And again, I think as a minority organization, just the understanding and the awareness that we have to go above and beyond some other individuals that are out there in the space. And really getting to the specificity. I had a call with the team yesterday and saying, all right, you're saying we have 49 new to medical access program. Is that 49 that transferred to us? Is that 49 that's brand new into the system? Is that 49 that were in the system and haven't been using it? You say 98 people did physical appointments. Okay, was that within the last year, last 3 years, last 5 years? All that tells a different message, especially when you're looking from a financial side and going back to Central Health, going back to Austin Public Health, and they say, well, you don't have, you only took care of 250 people this year, right? Someone else took care of 1,000. I want to be able to say, well, out of my 250, 50% haven't seen a doctor in over a year. Why that 1,000, 2,000, they saw, they're just regular patients, right? Our population that we're really trying to target is when we're partnering with community care, Lone Star Circle Care, Integral Care, and others, is the ones that are not incentivized through surveys, through gift cards, through food, right? The ones that are like, nah, player, right? That's who we're targeting, because that's the population that needs healthcare the most. And hopefully through us and through our specific branding, through our messaging, through our accountability, through our relationships that we have, hopefully they're believing that we do have their back.
I mean, I love that idea, right? And I'm a big love data, right? But I really do encourage all of you to watch the rest of this video, and hopefully we can send out the link. It's although I had known for a while, right, what you have been doing, because we were connected by BMSF, and I got the great honor to be able to moderate the work that you and Dr. Wallace have been doing for a while to create it, but still in its infancy. This video really does show anecdotes, and to me, those anecdotes are powerful. You do not need data to see the impact that Black Men's Health Clinic is making. And, I hear somebody say, well, you always use anecdotes, but the anecdotes are important. And you hit the nail on the head with the 250 versus the 1,000. Providing holistic care. And I want to get into the mental health aspects of what your clinic has now, what Black Men's Health Clinic is now providing, and talk a little bit about that. But what the services don't match up. It's like matching and comparing, like you said, apples to oranges.
Yeah. We already know, one, that there's a bandwidth issue just within individual systems. We also know that there's not enough providers for everybody that's in need. I think Williamson County or Travis County said one dentist for every 1,700 individuals, right? So understanding the reality, and so we're looking again, I always get this first word wrong, simplistically innovative is the goal here, right? It's not nothing new. We do it in other industries. And so I'm a big, what's going on in another industry and why the heck couldn't it work here type of guy. And so we're saying, okay, there's not enough dentists around. Well, there's dentistry schools. They got to do their hours and so forth. One of our outreach directors, he's coordinating with a barbershop school, right? I mean, there's people that need the hours, need the credentials and so forth. So, what are like Porter's five forces, right? What is the actual competition, and what are the ones that are similar to it, right? If I can't get a dentist, well, let me get the person that's in the pipeline to become a dentist. If I can't get the nurse, let me get the person that's in the pipeline. If I can't get the doctor, let me get the people that are in the pipeline, right? Because right now, you as an individual, you may say, I need to be seen like within a week. I just need someone to see me and at least give me something, and I'll be at least willing to wait another week to see the actual person, right? Versus, well, I can't get you in for another 3 weeks.
Yeah.
Right. And so we're looking at ways of how can we take care of people where they're actually physically, mentally at with the different people that are coming through. Plus, it also helps build the pipeline of competency, knowing how to engage with those particular populations, right? And so those are the different ways that we're looking at doing things. Again, with community care, right? The relationship there straight from the senior leadership is there's a particular population we just can't reach, right? We can't reach because we can't have that type of conversation. early on, they were doing a lot of the messaging and marketing for us, and the comments that would come back was like, are you authorized? Are you authorized to do that? Right?
Yeah.
You know, like, hey, we're community care, we're reaching out on behalf of the Black Men's Health Clinic. Like, okay, are you authorized to do that? Right? And so then when we started being able to get our own people, like, hey, Black Men's Health Clinic, oh yeah, look, sign me up. You know, it was the reverse way around. It was like, we're Black Men's Health Clinic. We partner with community care. If you got any issue, let us know. And they're like, oh, yeah, cool. I'm coming in. I'm coming to see the doctor versus the other way around. And so that's really the relationship that we're having, is getting people back into the systems where they lost trust, but hopefully we're the ones rebridging that trust. And we say, if you look at our website, everything is warm handoffs. Everything is care you can trust. And I had this conversation with our team a couple of weeks ago, that care you can trust, that word, that phrase, that slogan really means an aspect of every partner we have, we tell them we need to be able to gauge at every echelon of the organization. And so a good example would be the medical access program. Every other clinic, that individual shows up has to wait 30 days before they can get approved and be able to start scheduling appointments. And so for us, we said, that's not going to work. A lot of our people are brand new. That's not going to work. So we did like we normally do. We said, hey, Jason, CEO of Community Care, hey, we got an issue. Can we waive this thing? And then he shot an email to everybody else. And we're the only location that someone can come in same day, be seen, and apply for the medical access program, right? Same situation. One of their community health workers is designated and works in the office with us. And, you know, she needed to do overtime and so forth. And we said, all right, cool, we'll bring you on as one of our individuals as well, thinking that it's a double whammy, right?
Yeah.
Double whammy. Good opportunity, right? It's a double whammy. And so we sent in the paperwork like, oh, hold on, you know, the bureaucracy piece came in. Well, if she's contracted with you, then she can't use the systems and this and that. And so again, we came back and we hit everybody on the leadership at every echelon and said, how is this an issue? You would think it would create more access than less access. And so we got that rectified. And so that's what we're doing. Even with Seton, we're doing a partnership with them where the individuals from their emergency rooms can be referred to us to be able to take care of them and so forth. And again, you're like, hey, how does this relationship work? I said, well, when you have someone in the ER room, you call Dominique or you call this individual and they will call you back within a couple of hours. And again, I think it was just that shock, like, well, we don't want to bother them as if the weekend eat. No. That's what they're getting paid to do. Warm handoffs, right? Because that person that's in the other, that person that's being referred, that gives them a level of security.
Yeah.
That gives them a level of, okay, ownership. Now I need to show up and do what I need to do, right? And so we're again, because we're having these unique partnerships, we're able to take that funding from trying to provide a lot of the stuff ourselves to putting it into changing how people experience healthcare. And then we're putting ownership and saying, if you're going to be part of the Black Men's Health Clinic Care Network, this is how the relationship is going to go. We're not just doing email referrals and then you find out 2 weeks later, I didn't get it, or we had a bandwidth issues. No, you're going to call, we're going to figure it out, right? We're going to let the person know, hey, we made a phone call, we're still working it out. Even when it comes to patients, when they reach out, our team calls and says, hey, where are you at with insurance? What are you looking for? And amongst our mental health individuals, we have Contigo Wellness, which is Hispanic. We have Whole Life Priorities, which is Black individuals. We have Integral Care, which is, again, part of the medical access program. And so we're asking the individual, what do they want? And then we go back and we try to figure out what is going to be the best fit for them. And then when the team reaches back out, it's, all right, we talked to this and this and this. This is who we want to refer you to because we believe it's going to be the best to fit your need.
Yeah. I mean, I love the idea of this innovation, and they're not really, like you said, right? They're not new innovations, but they're just thinking outside of the box. And somehow in healthcare, we have these artificial boxes up that require these conversations, but it's a lot of work. Conversations to think about how to redesign the way that the waiver in the the MAP program and the fact that you were able to eliminate that 30-day wait period, it took a conversation, probably a couple conversations and some thought process. Just one conversation to get rid of some ridiculous, right, implementation barrier, a barrier to be able to improve access. But I really want to go back to what you said, and again, going off script, but what you said about the school connection and the pipeline issue. And if you can talk a little bit about the woman that was featured in the video, the social worker, and if that was still one of those schools, I think she was an intern, right?
Yeah. Madeline Johansson, she is from the UT School of Social Work, and she doesn't know it yet, so don't tell her. She asked to stay on. So her term ends up on the 24th. She asked to stay on part-time. She's going to go to graduate school up in, I forget where, up north somewhere, and she still wants to stay on. So that, and then we also talked about, because of what she's doing and how she's impacted just our processes, and helping us on the administrative side and the case management side to meet what we're talking about, that when that time ends, bringing her on the board, and showing again for us, it's a thing of, how are we showing people that we're invested in them? Yeah. How are we showing people that we appreciate their effort in working with us? Too often you take interns and you just use them and you just get what you need to get out of them. You say, thank you for your time, right? I mean, for us, and I think, again, because we're both kind of military, we're not kind of military, we're both military former people. So there's a lot of piece of recognition. And we just got done. We had 2 presentations from the UT School of Social Work on Monday in 2 classes, 9 students, and we gave them, commendations of appreciation for the work they're doing. I mean, again, we could pay money to get these researches and documentations and so forth. So, it only costs $5 to get something nice made, put it in a plaque and say, thank you, right? So why not do it? And I think that helps with where you see a lot of those partnerships that are coming from, not just the relationships that we have, but we're doing things that are actually showing that we're appreciative, and we're showing that just because we're a Black organization, we're not expecting Black individuals or minority individuals to work with us. We're saying that this is a business that we're doing, and there's a level of expectation. There's a brand that we're trying to highlight. There's a buy-in that we're trying to ensure. There's a care for the community and the people that we work with that we're trying to highlight. And these are the things that we have to do. Otherwise, we're not being true to when we say, care you can trust. We're trying to be in the community, that we're doing this differently, and that if you have an issue, let us know. We're going to rectify it, right? Though all those things hint towards that.
Every time I talk with you, I learn something so much more impactful. I think what you're doing in the pipeline, and we've heard from providers that are actually in areas that are particularly serving low-income, marginalized populations that are minoritized, that it really started from these experiences that you're creating. And so that bidirectionality of we needed this need. And so now we've got this pipeline and really helping people and morphing them to be able to have those experiences so that they can continue that is really something that I'm very grateful for. I want to talk about some of your partnerships. And again, maybe for this community, because many of us are in the lung area, but I was really compelled by the Texas Tobacco Free team and that work that you've been doing with them. And if you can expand on that.
Yeah, absolutely. A lot of partnerships is you're on Google and you find something, that's interesting. Let me apply for that, right? So, I mean, that's how Texas Tobacco Free came across, and signed up with them. And Lori Ritzdale has been amazing, and her team. And they used to be with the University of Houston, and they got transferred over to MD Anderson, and that just created a totally different opportunity there. And we all know the numbers when it comes to Black individuals and cancer and so forth. And I think it was just a great opportunity that they happened to move into another university that's their bread and butter of focus and so forth. And especially our relationship with Dell Medical School and talking with them about potentially implementing some piloting cancer services as well. And again, I think early on, long time ago, I remember Larry Sr. said, as the executive chief administrative officer for Central Health, and then the interim CEO, is that, man, I get so many emails where people are trying to sell me on fixing a problem I didn't know existed.
Yeah.
Right. And I really took that to knowledge. And then when I was serving as the director of veteran support and leadership programs for UT System over all the 14 campuses, I always got emails and reach outs by people that were veterans saying, hey, I'm a veteran. I want to meet with you. And then they're trying to sell me something too. And I really understood. I'm like, the higher up you go, more people are trying to sell you a solution and they don't even know what's going on in your house.
Yeah.
Right. And so a lot of our partnerships and so forth, we just tell them what we're doing, what we're trying to do, the brand, the piece we can't lose of the identity we want to be known for. And then we always turn it and say, so how can we support you? Where are you trying to go? What are you trying to do? And I think that's what has opened up a lot of the opportunities with a lot of the different partners, because we're not trying to sell them.
Yeah.
We're not trying to say, give us money to provide the services because of the way we have our partnerships with the FQHCs. We're really saying, all right, we already got funding from Central Health. We already got funding from Austin Public Health to be care coordination and navigation. The more people we're able to bring into the system, the more people we're able to show are using the system and are less hesitant and so forth, we're going to re-lock in the same amount of money.
Yeah.
I can just go back and ask for more money to hire more people to do more of that, right? And so I think that's a lot. Again, the uniquenesses of what we're doing is our services are at no additional cost to the client. We're being funded to basically make the system work better.
Yeah.
Right.
Yeah.
and so every new person that comes in and every new person that says, I have better faith in going to the doctor, that's a win on our end to go back to the entities and the agencies that are funding us saying, we couldn't get that person. You got that person. So.
Incredible. I mean, it's sad as a doctor to hear that we got to fix a system that really should be this way, right? This is the ideal. And somehow we've detracted so far from that. And bringing back, I also like the idea that you're bringing in more partners because you're all headed toward the same mission. And before you know it, right, you've now expanded Texas into a completely different model. You'll start low, and start here, but then that model now will begin to show people what care really should look like. I want to talk a little bit about some of the biggest insights. And if you can tell us some of the biggest insights you've had, both challenges, but also rewards, and creating this new model of, the model of care that we should have.
Ooh, insights. I mean, I go a lot of different ways.
Go lots of different ways.
Okay, so let me speak from the healthcare aspect first, right? And the political side is a totally different game. Every organization that we talk to at the executive level, especially the CEO person, they got it. They understood the need. They understood the population that they weren't going to reach. I mean, community care is the second largest provider with so many clinics, 26 or so. And I mean, straight out the mouth is like, we know we can't hit that population. I got the money, I got the funding, I got the people, I'm not going to hit it. Right? But they use consultants and all this to help message and further message themselves for a population that already says, I already lost trust in you. Right? And so I think that buy-in at the senior level was already there. And again, the other piece is Larry Senior worked with all of them. Right? And so I think and I work with most of them from my political hat as the mayor. And so I think there was also a piece of knowing who we were. Yeah. So it made it easier to buy in too, right? Because they're like, all right, I know what they stand for. I've seen the lashes, I've seen the impacts, and so forth, more so than just an organization or a person coming in and saying, I've been in this for 15 years. I got the solution. Yeah. They're like, I don't know you, right? So I think you had that double whammy, right? The double whammy. I think they had a double whammy, which made it easier to buy in. Plus, because he had that executive leadership, I had that political experience on being on the dais and dealing with COVID and the winter storm and having had certain conversations, we understood the bureaucracy side too. So we also weren't coming like some organizations from an advocacy standpoint saying, you could, you should, why aren't you? And for us, it's like, okay, what's going on? Why is it not gonna? And they're able to tell us, we're like, all right, cool, got it. Well, let us work it this way. You keep with your message. I got what you got to deal with, but let us work it this way. Let us work it that way, right? And again, that's where that piloting came from.
Yeah.
And so that I think helped enable a lot of that to be able to happen. That being said, as we started talking about we need access to Epic, which is the base system that most people are using, right? He's like, yep, cool. It can happen. Got it. We talked to Medium leadership. And they're like, well, give you access, HIPAA, this and all that. Talk to the lower,
Yeah.
like, you're not a business associate. We're like, here's the contract, right? And so the lower you go, the less of understanding the need there is.
Yeah.
We had situations where people come in like, well, you're not Black, so you can't be seen here. We're like, hold on. We're like, that's not how we play this here. Like, it's tailored, but it's open, right? And again, your community care or your integral care, you take care of everybody, right? So we're not restricting you either. Then it came aspects where we had to tell the person that oversees the clinic for us, hey, we want to sign this one lady up. Her husband's being seen here. And he was like, no, it's only men's only. I'm like, no. That's a spouse. And here goes to simplistically, see how hard that word is for me? Simplistically, innovativeness is that's the spouse. If I can get the spouse in with the spouse, right? Hopefully now, right? And then we're doing the same thing with our unhoused diversion effort, funding that we receive from ECHO for diversion. And so now we basically say, hey, if someone's going to be using diversion money, they need to be enrolled as a client. I don't care if they're male or female or whatever, right? Because now that's an exemption, right? And then schedule them screenings and so forth, because our goal in our conversation was if you just give the person the money for the temporary relief, we may never, ever see what health issues may arise. The stressors of going into potential unhoused, the stressors of trying to raise the money, right? You just give them the money, you never know. And so it's trying to find these ways of including non-intrusively health, but at the same time saying and identifying ways of we're for everybody, even though we're focusing not just on Black men, but Black men that basically are not enticed or incentivized by the traditional ways of communication and messaging.
Wow. Incredible. And then some of the challenges you hit on, I think that's an interesting one, is that they saw it, right? The CEOs and leaders saw it, and so they saw a need, and so that helped to bridge this gap. But actual doing it, right, was the hard part. And that's where you all have been able to really change the way that care was provided. I want to go back to what we talked about with the mental health clinic. We didn't really touch as much on that, and your decision to begin to partner clinical care, which I consider hand in hand with mental health, and how you were able to bridge those.
Excuse me. So integral care is, make sure I get this right, Larry Senior, because integral community care, when it was created by the county and central health, they separated out the mental health into integral care. So the medical access program is really those two systems together, right? For the population below the poverty level for population. And again, we knew most of the individuals, so it was kind of, hey, this is what we're doing. We want to be in the coordination for physical, mental, and social. Those three areas, they tie to each other. And so it was this reaching out after we fleshed everything out. So this wasn't a thing we just went to friends and said, or people we work with and said, hey, we got this idea. Are you on board? No, I mean, like, we fleshed it out. We spent a whole year doing this and doing that, bringing people in, they picking it at it, right? Doing the whole thing that you're supposed to do. And then going to them and saying, this is what we have. This is what we're thinking about doing. This is why we're going to do it this way. How can it be beneficial to you? Right. And again, the connections get you in the door, but you can't over rely on the connections, because if the business goes bad, you just jack them up. Right.
Yeah.
And then they're going to go tell someone else that you jacked them up. Right. So it's looking at it that way. And that's kind of what we really did. Not kind of, that's what we did in that aspect was really fleshed it out to kind of really understand what we need to do. We talked with Central Health and Community Care. I mean, we had probably a year's a discussion with Jason Fournier, and he helped kind of build it out. When it came to asking for the funding from Central Health, he helped lay out how the approach needs to happen. Same thing with Austin Public Health, talking to the executive director there, Adrian Stirrup. I mean, it was a lot of conversations on where is the funding at? And this talking with even your grantee here, where's the funding's at? What's the focus? How is what we're doing either associated with that or not? How is it, all those things, while at the same time making sure you don't go outside of the original intent and why you are creating this organization, right? And then as they're starting to see the needle move, then you're kind of like, all right, cool. Now we're going to add this, right? And then as you see the needle move and you see improvement, you're like, all right, cool. Now we're going to do this. Right. And then when they start pushing back, you're like, well, did you not see the last two things we did in the outcome? We going to do this. So that's kind of how those relationships have been working out.
That's incredible. And so if you had to go back to the first 6 months, can you talk to the audience about the early lessons during that first 6 months?
First 6 months. Be very, very, we all got friends. We all got people we know. We all got people in positions. And we all know once you get them to the table, don't do nothing. Right? So knowing who to bring to the table, knowing who just needs to be a name, who just needs to be a position, and knowing who really needs to be at the table to help move things, help put in work. I think the same thing with, we had a steering committee and they just sit there and look, and you're like, okay, am I wasting my time? Like what's going on here? Like we're telling you what we're thinking and we're wanting feedback. And they're just like, okay, cool. And you're like, you know what? Forget y'all. And so one, don't waste your time.
Yeah.
With people that are in positions and titles, even if you want to work with them down the road, because you're going to lose time because they're not really saying anything, right? They're just there because you asked them to be there. They may not be fully invested. I always say Larry Sheen and the team is bees the honey. When you start producing, then they're going to show me like, hey, we in a different level of relationship now. Right? When I came to you 6 months ago and I wasn't hot, kind of like, what's his name? Oh, you don't know. What's the name back when I wasn't hot, you ain't want me, right? Mike Jones, right? It's like that, right? And so it's having that mentality. I do that. But it's like having that mentality, right? Of you ask the people, but you categorize really, really need them at. And you give them enough rope to hang themselves. So then when you do have the bees, the honey, you're like, hey, man, you remember when I came to you 6 months ago? The relationship different now, right? Those are things that we had to learn. We also had to learn that we had to engage with people. On the political side now, right?
Yeah.
I'm in a chat with like 15 plus elected officials, and I just got done reading them 2 days ago. And it's like, walk the talk. You got organizations, you say there's things that need to happen. And most of y'all probably say this in the healthcare space. You're in the circles. They say, we need to do this, we need this, we need that. And if everyone comes, I'm gonna be all on it, I'm gonna be all supporting it. Then when it pops up, they're like, right? And so you see that again here. And again, it's like, okay, as much as we want to be pro-Black, as much as we're building a Black healthcare system where the funding is actually not coming to us, it's going through us back into the Black community, right? You would think there would be more support. You would think that, like the new Black Fund and all them, right? You think there would be that support there, and it's not, right? So then you basically say, okay, cool. I'll take other people's money that's invested. I'll work with other people that's invested. And when they say, well, why you looking this way or why you taking that money? And you basically have to come back and say, again, it's about the mission. And if you're not about the mission, and you're not about the vision, and you're not about what you actually are talking about, I don't need you. I might know you. I might have worked with you. But when it comes to this, there's a line. either you gonna stick up to what you've been talking about or you're not. And so we've had to have those conversations with people, and we've had to let them know, like, this isn't a game, right? We had an email, not an email, the person called me last week or earlier this week, and we actually saved someone's life by how Madeline, she's been going to the public libraries. And this one person that she's been seeing time after time, she finally got that individual enrolled to come in. And I think it was just the socialization piece. I mean, like, he basically really said, like, you saved my life, right? I mean, you hear that story a lot of times about other organizations, but then when you really ask them what they're doing, they're more about trying to get more money. They're more about trying to get, I had an event, I had 1,000 people, right? But I want an event, I want 50 people that really want to be there, right? And that's what we're trying to do. That's what our mission is. That's what our focus is not trying to get the big numbers. Yeah, we want the big money, but it's all about how are we really truly impacting? Because when we slow build this thing out, it's going to survive. It's going to last. And we're going to have people that are going to be able to promote it. So promote it based off of the impact that it's had on their lives.
Yeah, I think that close examination and those conversations, I think, are key, is being transparent. And it's a tough conversation to have, but saying, hey, you're on the health equity tourism bus, not really in it for the mission. When you're ready for the mission, you come back. I want to, it's so hard to think about the next step, like what you could tell the audience in terms of how they may be able to think about a problem in their own community and go about solving it. What would be kind of the number one thing that you would address with the audience, the most important aspect to consider when starting an innovation like this?
You know, for us, next steps and even now has been, again, simplistically innovation. How do we really truly be? I did a speech with the Black Health Professionals Organization over with UT Austin on Saturday, and one of the conversations that I basically said there was these buzzwords, right? Cultural competency, meeting people where they're at, right? Yeah. So support your own. Like, what does that mean, right? What does that mean? Because nobody's doing it, you know. And so for us, when we talk about supporting your own, right? And this aspect is not being apologetic, being unapologetic. You know, so many people have said, hey, it needs to be men of color clinic, or, you know, you need to have Hispanic faces in there. Well, if you look at the full slide, you'll see 30% of our patients have been Hispanic. So they have no issue going into a place that says Black Men's Health Clinic, right? And again, let's take it to a different industry. You know, when you go to a Black barbershop, a Hispanic barbershop, or a Caucasian barbershop, you don't walk in and say, hey, man, why you a Caucasian barbershop? No, you know, they're going to take your money, they're going to cut your hair. And it's the same way here. Just because it's a different industry, right? Why do we have this barrier, right? If you do good work, people don't care about the name. They coming for the service, right? We have a particular population we're focusing on. We got to make it feel like it's theirs. Now, they're going to go around and say, hey, man, I got good service. You can go to Black Men's Health Clinic and offer the feedback. You don't let anybody in your house. You don't just let anybody in your house, but you let the garbage person come in your house. You let someone bring furniture in your house based off of recommendations from your friend. And you lower that level of distrust. And that's the same thing we're working here in longevity, right? The barbershop program we have, you know, our barbershop program is really different in a sense of we're saying the barber doesn't have to know about healthcare. And we're not intrusively bringing health in, because there's a lot of people, hey, you have to bring health. I'm like, you don't know what the environment is. You don't know what the circumstances are. When I go get whenever I go to a barber and get a haircut, I ain't going there to talk about health, right? And so you potentially make that barber lose clients, which then turns around and makes them not want to introduce health. And so what we said was basically, hey, you can tell a client that's in your seat and say, hey, do you want $25 off your next haircut? what's most of y'all gonna say? Yeah. Right? Yeah. And he said, all right, cool. Well, if you schedule an appointment through the Black Men's Health Clinic and do the appointment and then upload your paperwork, they're gonna give you 25 credits on your account, and you can come back to me and give me them $25 off your next haircut. That's simple. That's scalable, right? And so we have that program. And so back to what we're trying to do is add more barbershops.
Yeah.
Right? That's outside the four walls. Our partners, Communicare, they're all over the place. So you can either come to us or you can go to one of them. Again, it's one of our partners. Enroll with us. For our unhoused, I already told you about that one. Instead of just giving the money to someone, right? Austin did that during the during COVID. They gave $1,000 checks. Most of them people went and bought shoes and stuff. And they came back and said, hey, I still need help. And so for us, it was a piece of how do we tie it in that when we give someone money, or again, when the money came out for businesses, you said, hey, here you go. Here's the money for your businesses during COVID. And then they said, after you give you the money, you need to start using these sessions with us to learn how to manage your money. How many of them businesses actually went through that? Right? So it's understanding that once you give someone something, they're not going to follow through. I don't follow through on a lot of stuff once you give me something. We're all like that, right? You know, I don't mean that in a negative sense. I mean, like, put that audible out there. I mean, like, you don't give someone like credentials and then you say show up for training or orientation. You're like, man, look, you already gave me that stuff. I'm kind of busy, right? We all do that in some aspect. So in this aspect is hey, cool. Want to sign you up. We're going to give you the funding to get into some housing or whatever it is. But you also need to sign up as a client. You also need to schedule to do a screening and so forth, because we want to make sure and see if there may be some other underlying issues that we would otherwise be able to potentially capture if we just gave it to you, right? And trying to do those things up front. We partnered with sports. So we're going into our second title sponsorship with an organization called King Social League. They just went from 10 teams now to 16. So we make sure all of them are signed up as clients. And then what we did was work with Austin Public Health to do concussion screenings and blood pressure checks before the games for all the players, right? And again, non-intrusively. And then we also have our table there and so forth. And then Madeline and others go through the crowd and talk with them and this and that. But we also have people at every event that we do. We have people that actually schedule appointments on site. And that was one of the big things that we highlighted and told Community Care. You good? No, when it does happen, it was like crazy. We told them that it's crucial to have people on site scheduling appointments. And that's where they come back sometimes and say, well, we have the app. I'm like, well, they may not be Community Care patients. They may not be one of your patients, so the app's not going to work. Two, if we do this whole normal referral, go to the website or reach out, it's not going to happen. If we're able to say, oh, you want an appointment? Okay, we can get you slotted in at this time, right? It's a certain level of ownership. We saw a lot of our appointments being filled that way because we're getting people on site and then following up with them and checking with them to make sure that they're still good or if they need to get their appointment rescheduled. In the video, you'll see social determinant support areas like transportation. 23 were scheduled for transportation. They're scheduled for transportation to make sure they showed up for their appointment, right? Usually, you don't show up for your appointment, you get what? A nasty gram email says you didn't show up, don't show up again, you're no longer a client, right? Type of stuff. And so for us, it was, how are we treating them like they're VIP, like they're senior leadership, right? For any of us, we can go into the clinic, go into your place of work, talk with someone, they'd be like, excuse me, ma'am, sir, I need you now, right? Why do they need to sit for an hour and a half just to be seen for 20 or 30 minutes? Let them come in, go back, update their paperwork with Dominique or whoever it is. Excuse me, I need them now. We're ready. The doctor's ready to see them. Go see the doctor. Okay, we're good. If you want to go back to Dominique or whoever it is, go over and say, all right, do you need any other services? All right, let me update your filing here because I know you're going to have a mental health appointment in a week. So let me get this stuff so I can make sure I let the mental health person know what's going on your health side, on your physical health side, right? And so at least that hour and a half they're with us is more engaging, and they walk out and be like, all right, I just didn't sit there and waste my time. Like I could have been doing something else for an hour and then showed up for my appointment. And so those are the things that we're trying to do, is really look at it from the lens of the patient experience.
Yeah.
And we're able to do that because we're not providing the services right now. We're able to really focus on the patient experience and advocate for the patient experience. And I think long-term phase of what we're trying to do is understand what our partners legitimately can and can't do, bring in nonprofits to fill those gaps, understand what those nonprofits legitimately can and can't do. So in that way, with funding that we do have, hopefully by that time, be able to bring on staff to fill that third tier of gaps.
Incredible. We're just at time. I mean, I could go on for hours, but just want to thank you so much for what you're doing. Dr. Wallace, you as well, for this great vision and for creating this. And hopefully for those of you in the audience trying to take one nugget back as homework of what we can do in our own communities to try to improve care. Thank you so much.
I appreciate the invite.
It was wonderful. I'm just always so impressed. Everything. All about it. So many questions.
Hello. Thank you to both of you. That was really great. I feel like if I were living in Austin, I would also be at your clinic. So you're lucky I'm not here. But that was a really great chat. I felt like I was really part of the conversation. So I really appreciate that.